everyone. Good evening to those of you on the other side of the ocean, and good afternoon to those of you on this side here in New York. Welcome back to TIO 2024. This is the main stage. I am so thrilled for this session 2.3. We have an incredible afternoon for you guys, 3 fantastic lectures, and then 2 live cases from 2 fantastic centers. I am really excited. My panelists are here today, Dr. Natalia Pinilla, Dr. Joost Daemen, Dr. David Hildick-Smith, and Dr. Ajay Kirtane, who's going to join us a little bit later. Thank you. Thank you all 3 for the 3 of you being here. Natalia, David, and Joost, it's great to have you. We're going to have so much fun. These 3 lectures are going to be fabulous. We'll have a little bit of a Q&A after every one of the lectures. I'm taking live Q&A, so put in your questions. I'll get them answered, I promise. And we're going to have a great time discussing imaging. It really has become the foundation of what we're doing now, especially in complex PCI for coronary work. And I think there's no better way to kick off this session than engaging our viewers with a poll. Here is the poll, everyone. Every PCI cath lab needs to have OCT and IVUS imaging. What do you all think? Yes? No, only IVUS? No, only OCT? No, invasive imaging? Only coronary physiology is needed. Go and vote. Please vote. We're going to come back to the results later. And at this time, it's really great. I'm so excited to hear our first presentation by Natalia, who's going to talk to us about invasive imaging updates. There's no one better. Natalia, you got the floor and our attention.
Thank you so much, Roxana, for the introduction, and thanks for the invitation to participate of such exciting meeting. I agree with Roxana, we are going to have a great afternoon. So I'm going to go over the imaging updates. These are my disclosures, and this is a broad topic. So I felt what is best to share in a TIO today. So I'm going to review the most recent imaging data, which is 2023 and 2024 that are very excited so far for imaging data. Then I'm going to go over the new imaging systems that have been launched recently. And at the end, I'm going to go over what is the research heading in invasive imaging. So let's start with data. And again, in 2023 and so far in 2024, we had amazing data for imaging. So let's start reviewing. One of the most important studies that were published in 2023 is the Renovate Complex PCI. And this study was led in South Korea in 20 centers across South Korea. We need to understand that this country has a high percentage of imaging-guided PCI, over 90%, and 1,600 patients were randomized 2-to-1 to undergo imaging-guided strategy versus angiography-guided strategy. The usage of the imaging technique was decided by the operator. 75% of the patients had IVUS and 25% of patients had OCT. This study had real complex disease, like 60% of patients had diffuse disease, 30% of patients had bifurcations, 20% unprotected domain. So these were real complex coronary artery disease settings. And this study showed that actually an imaging-guided PCI led to 36% reduction of the primary endpoint. So this study was very important for imaging, showing how good is imaging in complex coronary lesions. Then ESC was big for imaging, and several studies were presented here. One of the most important for OCT was Illumian 4, and I want to go over the most important details of this study. It was a randomization 1-to-1 of 2,500 patients done in 80 sites across the world, randomized to OCT-guided PCI versus angio-guided PCI, which was important in this study OCT expert operators were accepted as investigators. And in the inclusion criteria, not only anatomic criteria, but patient profile was allowed as an inclusion criteria. As you can see in the slide, not only and, but or was allowed, meaning that high-risk patient, only medication-treated diabetes was in no criteria to be part of the study. And in the high-risk lesions, just note that ACS was allowed as an inclusion criteria. Both of these ones actually don't secure that these patients have complex coronary artery disease. Also in stem stenosis and CTO, where are difficult settings to get an optimal PCI, even guided by imaging. So the primary imaging endpoint, minimal stent area, was met. But unfortunately, when the Tiger vessel failure, which was the clinical endpoint, didn't show any difference between these two strategies, OCT versus angiography-guided PCI. This is an important message for this study that maybe it's not just about the patient profile, not just about having diabetes or presenting with an acute coronary syndrome. Probably the most important features that benefit from imaging is the high-risk anatomic features of these patients. There is a beautiful graphic in the supplemental material, the stent thrombosis, which is completely flat. And we almost never get a graphic like this suggesting that if you had an OCT-guided PCI, this is very safe for these patients. Only the stent thrombosis that happen in the OCT-guided arm happen around the procedure. After that is completely flat. So having an imaging-guided PCI is actually very safe. Then we had October, a beautiful trial that randomized 1,200 patients to OCT-guided versus angiographic-guided bifurcation PCI 1-to-1. And this study showed that having a bifurcation PCI guided with OCT led to an important reduction of the primary endpoint, around 30%. And in this study, also, the core lab was able to analyze what were the most important features of these events. And as we know, in a bifurcation PCI, it's very important making sure you don't have abdominal rewiring and guide catheter collision. And the OCT core lab in this study showed that these two are the ones that led to the events most likely. Then we had IVUS that this study was needed comparing OCT versus IVUS-guided strategy. And this study was a non-inferiority design for the OCT guided group. And it showed equal for the primary endpoint, suggesting that OCT is not inferior to IVUS when guiding a PCI. Then we had important network meta-analyses that were published both this year, February and March, led by important professors that we have learned quite a bit. So the first one is Professor Stone that published this in March, the network evidence of all outcomes imaging-guided PCI versus angio-guided PCI, showing that intravascular imaging actually reduces target lesion failure in around 30%, cardiac death in 50%, myocardial infarction in 20%, stent thrombosis in 50%, and even all-cause death in 25%. These findings were consistent with the other meta-analysis published, led by Dr. Capodano, that was consistent in this meta-analysis, was stated that most of this data is actually led by IVUS studies. And not only that, but that last month, like this month, we had this publication on cost-effectiveness of from the Renovate Complex PCI. And this study, the cost-effectiveness study, was used the Markov model that simulated three scenarios: the post-PCI death and also myocardial infarction. This was the data from the South Korean healthcare was used, that this data was reporting in US dollars. So you see how around the procedure, imaging-guided PCI procedure is around 1,500 US dollars more expensive than an angiographic-guided PCI. But over time, in a simulation lifetime, over 10 years, actually this graphic reverses. And around, there is an incremental medical cost of around $10,000 in a simulation of 10 years. So this is a very important message because the cost of the patients having angio-guided PCI is led by adverse events. So after reviewing the data, let's see what is doing the imaging systems. And this is very exciting because both OCT and IVUS have launched systems with the incorporation of artificial intelligence. So the Ultron 2 has automatic calcium detection in orange, displaying both the cross-section and the lumen profile, and also this white artwork indicating the thickest calcium. Not only that, but now we have automatic analysis of the EL detection with the white interrupted line, making easier to decide which is the size of the stent, not only the length, but the size, looking into a mid-size between the EL and lumen. So this is making our procedures much easier. And not only that, but you have the dynamic angiography view that enables to use the live angio with your information from the lumen profile, and you have option to zoom up to 600%. From the IVUS from the Boston, we had the Avigo, which is it's unbelievable that finally for IVUS, we had this automatic lesion assessment. So we had accurate lumen and vessel borders with a lumen profile for the PCI planning, showing the distal, proximal, and minimum areas with markers. And not only that, but also now the pullbacks are faster, and you have up to 8 millimeters per second in the IVUS as well. And this is very important to increase the usage of intravascular imaging in the cath lab. So to finish my presentation, I also want to say, where is research heading in invasive imaging? And we have ongoing studies for PCI optimization. We have the IVUS shift from the group from Erasmus. We also have the optimal guiding a PCI in the May. We had the ESME, also IVUS versus angio-guided PCI in STEMI, and we also had the improved study. So it's interesting how the PCI optimization is not only heading to complex lesions, but also specific anatomic locations. And now, what is the future of this research now? So we know these technologies have like a very accurate analysis of the vulnerability. So now we are trying to understand whether preventive PCI works or not. And we have the PREVENT study that is going to be presented in ACC in a few weeks. Interclimate study comparing OCT versus physiology to guide PCI in non-fulcral lesions. We have all CT contact. We have combined intervene. We have vulnerable, and we have the complete tool that I have the privilege to be part as an investigator. And all of these studies are going to let us to understand whether stenting vulnerable plaques with moderate stenosis is beneficial or not. So as a take-home message, I think we had enough data to say that intravascular imaging-guided PCI improves event-free survival and reduces mortality. And then I also had to say that it's actually cost-effective based on the publication for the Renovate Complex PCI. Future research will give us insights on the type of lesions and clinical scenarios that will benefit the most from an imaging-guided PCI, and the artificial intelligence that has been incorporated to these systems with faster pullbacks, with automatic lumen and vessel borders and dynamic angio will likely increase the usage of these technologies in the cath lab. And ongoing research is focused on imaging-guided PCI in specific clinical and anatomic locations, and also preventive interventions. Thanks for your attention.
Well, that was fantastic. Bravo. What a beautiful way to really a complete presentation. Such a rich environment for future research, but so much data that shows us the importance of imaging. Thank you, Natalia. So let's open this up for a little bit of some discussion with all these fantastic panelists. First, let's go to this new technology of the Ultron. Is it a blessing or a curse? What's the value of this optimization? Let me go to you first because you brought it up, Natalia, but then I really want to hear from Joost and David because I worry with artificial intelligence, are we going to overstep our boundaries in terms of overstenting? So let's just let's hear what you think.
Yeah, thanks for that question, Roxana. I have been using the Ultron 2 for 3 months, and I have to say it's a game changer. I think the most important difference is that you have 2 options. You have the flexible mode, which is closer to the active view software that leaves options for the operator to make most of the decisions. And also you have the guided mode, which is similar to the Ultron one. So I think it opens both options to the operators. And I agree with you. Usually when you're using this Ultron, your eyes go to the EL detection. So probably we are going to go even longer than what we were going before. But I have to say that supports your PCI, and it makes it very efficient and very safe because you're selecting very safe landing zones and very accurate lumen assessment and selecting the right size of a stent. So it's been a game changer for me, and I love intravascular imaging PCI. So I'm probably biased towards that, but the Ultron 2 is definitely a game changer.
Great. David, Joost, let's go to you first. David, what do you think?
Yeah, I think specifically with relation to Ultron, obviously it's a big step forward. I think it is a very good technology. What you mentioned though is something that we have to bear in mind. There's no doubt that the longer length of stent that we put in, the more we risk some form of complication, whether acutely or in the longer term. So we do have to bear that in mind. And secondarily, when people are going to a new technology that shows them the EEL, they are definitely at risk when changing to that system of slightly oversizing the stent. There's always a slight risk with this, with each new step of technology with intravascular imaging, that you will get a few cases of perforation where people have slightly over-egged the pudding in order to try and get a perfect result. So, I mean, it's a minor comment, really. Obviously, the imaging itself is fantastic quality and should allow us to do better stenting. But I think we do need to keep in mind more and longer stents is not better. So, try and maintain our focus on treating the bits that actually absolutely require stenting or potentially drug-coated balloons. So limiting the stent implantation rather than extending it, because that's all we can see on the intravascular imaging.
Joost?
Yeah. Well, Ultron 2.0, I don't think it's a game changer. What I do think, and what I personally, and this is my personal opinion, what I really like is the AI-based calcium and EEL detection. I think that works quite well, and that is unprecedented in any type of intravascular imaging modality thus far. So I think from that perspective, Abbott did an amazing job in making this now applicable and available to everybody who's using their system in across the globe. So that is great. It helps younger physicians who are perhaps not that much comfortable and trained in recognizing a media and recognizing calcium. So from that perspective, it also has a training purpose, which I like a lot. What I dislike a bit is the fact that the system really forces you to follow a specific workflow. For instance, I don't want to do a co-registration in a simple post-PCI pullback. I don't want the system to tell me that for each lesion, the stent length should be 23 millimeters, simply because that is the most commonly used stent size. So there are a lot of things that I think can be tailored and fine-tuned a little bit. But no, bottom line is, I have to say I like it. It's a step forward, and I think it's an example for how other systems can evolve.
You know what I think about this Ultron? I actually think it's fantastic, because it really gives you the no excuse reason why not to use OCT, where you're not really understanding what the images are showing, which you all discussed. But I wish that they take this artificial intelligence and customize it to operators with their operative choices, so that if it learns from the operator, isn't it going to be better in terms of understanding? Well, Joost likes it. He's going to use a 15 millimeters, 12 millimeter stent, even though we're telling him it's 23 millimeters. And guess what? His results are perfectly fine, and there's no issue. I often believe that we're underutilizing AI to customize it for what we all did. And I'm wondering if that's sort of coming in the future. It literally is a no excuse of why we should be using more imaging rather than less. And one of the big questions that's coming up, it says, well, what do you think we should use IVUS, OCT, or imaging in left main PCI? I can't imagine that you would do you would put a patient through a left main PCI given everything we have known without imaging. And, to me, it's just obviously the answer to your question, Dr. Sheikh, is exactly that. Of course, you should use the imaging. Which one? I believe, and I'll take it coming back to you, is really what you're most comfortable with. And if you're really uncomfortable looking at OCT images, don't do something you can't interpret, then that's craziness. So do what you are most used to and learn how to do it and come to these imaging sessions and learn from the experts. I think it's a great way forward. I don't know if you guys have any additional comments to that.
Yeah, Roxana, I totally agree with you. I think the left main PCI is a complex procedure itself. So don't do something you don't feel confident doing. Just use the imaging technique that you have used the most, and that's probably the safest for these complex procedures.
Well, before we go to Joost's presentation, I want to see the audience questions. Can we check that? Can we just check the poll, what the poll showed, or should we come back to the poll? Is the poll ready or not? I'd like to see the poll.
Mm.
Okay. Well, this was before your speech. This is fantastic. So most everyone feels this is a group of enthusiasts, imaging enthusiasts. We love that you're all listening to us. Well, now let's go to Joost. He's presenting on non-invasive imaging for interventionalists. You're up next, Joost. We can't wait. You have our attention.
Thank you, Roxana. So it's a pleasure to be with you all today to present. Being an invasive imaging specialist on non-invasive imaging. So I have to admit, I picked a couple of things within the next 10 minutes to highlight, which I think are of interest. Obviously, this is a topic to which you can elaborate on for hours, but I will keep it focused on a couple of things that I think are of interest. If we're talking about non-invasive imaging, I think it's imaging and physiology because the technology is evolving. But what is important is that all of these things that are finally the base of what we're all doing are driven on coronary imaging, which can be either invasive or non-invasive. Invasive, we've just seen, IVUS, OCT are the key parameters, but most commonly used across the globe is still the CT and the coronary angiography. However, if you use specific software packages to use these images to get more out of it, for instance, physiology, you can get, for instance, a physiological lesion assessment within just minutes using just non-invasive imaging. That can be a CT scan, but that can also be a 3D reconstruction of the coronary angiogram without the use of invasive coronary instrumentation. And that is critical because in a lot of labs, there's just angio, and these labs could benefit from these type of solutions in order to get a more comprehensive view on the coronary anatomy as compared to just plain CT or coronary angiography. So coronary angiography-based physiology is something that you've all have seen in the last decade. It has clearly emerged. Now 4 to 5 different vendors are commercially available. Initially, a lot of critiques, whether it's with respect to the accuracy of these systems. This is just one example of the phase 2 trial that we recently completed, showing you the correlation between invasive pressure wire-based physiology and a angiography-based, in this case, VFFR, with the CAS system of biomedical, very accurate technology, sensitivity, specificity figures, well above 80%, correlation coefficient of 0.74. So with that, I do believe that angiography-based physiology is a technology that will remain and will take away some of the invasive assessments that we are currently performing. One item on clinical applicability of angiography-based physiology. I think this technology is specifically suitable for patients that present with chronic coronary syndrome. However, you need to have proper angiographic images. You need to give your nitrates, don't move the table, and you really need to take meticulous attention to making proper orthogonal angiographic projections Otherwise, all of these angio-based physiology platforms will simply not work properly. Don'ts, patients with osteolesions, severe overlap for shortening, all of the items in which these systems are simply not able to make proper 3D reconstructions prohibit the use of these systems. So this is critical. Items that have not been defined yet is the use of these types of indices in the ACS system, cardiac transplant patients, and in bifurcations. That is something that still has to be defined. What about the use of angio-based physiology in ACS? I think this is something that is important, and I briefly wanted to highlight. Angiography-based physiology is highly accurate, but not necessarily in patients presenting with non-STEMI. This is the key result of the FAST OCT trial that we presented last year at EuroPCR, showing you that if you do angio-based physiology in intermediate, typically non-Cooper lesions of patients presenting with non-STEMI, there is a very close correlation to the minimal lumen area as identified by OCT and the presence of a significant VFFR value defined as below 0.8. However, and this is the tricky and the important item, 42% of patients with a negative FFR or VFFR had either signs of plaque rupture, amylase below 2.5, or presence of plaque erosions or thrombus with area stenosis above 75%. So that tells me that in patients presenting with non-STEMI, imaging is still the way to move forward. But then invasive imaging in particular, because these unstable patients simply go to the cath lab anyway. This is just one example of the trial. This was a patient with a thrombotic occlusion in the right, and then this intermediate lesion in the LAD. Natalia knows all about this because she did this analysis in the complete trial. VFFR in this case negative, but if you would have done OCT, you would have seen a TICFA with a minimal lumen area of 1.6 and a plaque rupture, which is visible here. Well, so far, image-based physiology, for those of you who are not certain yet about how this will be embedded into your routine practice, 6 to 7 large randomized controlled outcome trials are currently ongoing following the recently presented positive results of Favor 3 China. 7 trials on the way, some of them completed enrollment. Fast 3 is the one we're running from Rotterdam, also almost expected to complete enrollment next month. And with that, I strongly believe that the new revascularization guidelines will get a modification into the use of physiology, either invasive or angio-based, in patients in whom evidence of ischemia is not available upfront. So that is, I think, something that deserves attention. Guidelines, at least for Europe, are scheduled for later this year. But then, of course, certain discussions will need to follow based on the pricing models, license fees, etc. So far, angio-based physiology with the current commercially available software platforms, but there is more. And we have already talked about AI. This is just an example about a new system called the AutoCAD FFR solution, completely using non-invasive technology. You make your standard coronary angiogram. This system automatically picks the images from the DICOM system and uses a fully automated AI-based algorithm in order to get a 3D reconstruction of the coronary anatomy using a training model of over 400 million single frames, and gets you a complete physiological result of the coronary anatomy in just 37 segments. So this is, I would say, a game changer and completely different as compared to the other commercially available software packages, because there is no manual user interface in this software platform. So that could be a game changer. Recent validation work illustrated that this actually works very accurately. So just to briefly highlight the AutoCAD FFR system that you may encounter sooner or later in meetings or in routine practice. No mentioning about non-invasive imaging without mentioning CT scan. CT obviously was the first modality in which we learned to use non-invasive physiology in patients that had upfront CT scanning, a model that also uses computational fluid modeling in order to get an impression of the pressure gradient across a specific segment. With that difference as compared to angio, that the model is a little bit more comprehensive because it can take into account the true 3D geometry, plus the myocardial mass, which is something that cannot be taken into account using angio-based physiology. So that is something that proved to work very accurately. And now with the photon counting CTs, increased resolution, and the use of, for instance, the HeartFlow or Siemens models to get a modeling of what you will do with your PCI in each individual patient, is a game changer in my perspective, particularly for patients who present with stable angina. This is just an example of patients that had lesions up front of system models, how the physiology will change pre and post PCI on the top row, and in the bottom row, how that was confirmed by invasive physiology pre and post, just to say that this system works very accurately for planning PCI. Moreover, and this is something that we've been used to for many years, planning CTOs, that is also in which I think non-invasive imaging is playing a crucial role. Specifically now the resolution is getting better and better. If you plan your CTO, the CT will give you information on occlusion length, the tip, do you have a blunt or a tapered tip, do you have calcification of yes, how much calcification, is there tortuosity, yes or no. So those are all kinds of details that you will get from the CT scan pre-PCI. More specifically, this is one of the examples of a paper that Patrick Royce recently published based on the randomized control trial he's running on a topic about revascularization planning based on CTs up front. So the CT will get you a 3D reconstruction and can get you a specific modeling of all the physiological improvements you will get with putting specific bypasses to specific segments along the coronary artery tree. Whether this is going to result in significantly better outcome as compared to conventional strategies is something we will learn in the upcoming years when the trial is completed. More on CT, it's not just about anatomy and physiology, it's also about patient stratification. This is just some data from our Japanese colleagues illustrating that the CT will not just give you a 3D reconstruction of the lumen, but can also tell you something about the perivascular fat, which has identified as a very strong predictor of cardiovascular mortality if you end up with fat attenuation indices above 70. And these figures may guide early targeted primary prevention and intensive secondary prevention in patients that underwent CT scanning for either preventive reasons or for diagnosis in case of chronic coronary syndrome. So this is something that you will clearly see more and more in the future. More advanced is the PET-CT program, also being able to show you vulnerability of lesions that are at high risk. But with that, I need to make a side note, because all of these hotspots that you see on these fancy images are typically images that have been made in patients presenting with acute coronary syndrome. And in those patients, my personal belief is that these patients still may benefit from more invasive assessment as compared to a CT upfront. So in conclusion, imaging-based physiology indices are rapidly emergent in multiple entities. And geography-based physiology is ready for prime time. There is an important, potentially future role for AI-based user experience, as we have already discussed with the Ultron. CT-based procedure planning is emergent and will likely play a huge role in the future. The results of multiple large outcome trials on the topics above are eagerly awaited. One caveat and one side personal note I want to make is that in patients presenting with acute coronary syndrome, as of today, invasive imaging remains the gold standard. Thank you.
Wow, fantastic. What a complete evaluation of the angio-based and CT-based physiology and incorporation into our practice. I have a lot of questions. I mean, I think first and foremost, how do you see this, the angio-guided, what you showed us, the angio-guided physiology ready for prime time, not perhaps for acute coronary syndrome patients, but is this going to replace intracoronary physiology? Most of our data, pretty much most of our data, is on invasive intravascular physiology with all of the famed studies and the previous studies that have been presented with both FFR and IFR. How do you think this fares together?
Yeah, well, The short answer is yes. I do believe this is going to take away a lot of the share of the pressure-based physiological assessments that we're currently doing. I mean, there is a wealth of trials now with different platforms, with studies run across the globe by different groups of physicians that have demonstrated there is a very close correlation to angio-based physiology and the invasive way of assessing using a pressure wire. So I think that discussion is to me a no-brainer. With that prerequisite is that you need to be able to make proper angiographic images. In patients which has a lot of foreshortening, overlap, and so on, I mean, these systems will not help you. So that I think is answer or point one of the answer. The second is there's a huge, I would say there is an increasing attention and interest in assessment of the microcirculation. And in that perspective, I think we're not there yet with angio-based physiological lesion assessments on those cases in which you find patients with no clear epicardial disease, but still typical symptoms in which you may want to do a microcirculation assessment. Well, in those patients, I think measurement you're using thermodilution, flow, continuous flow, and so on is still the way to move forward. But for routine practice, I think angio-based physiology is an important new development that will replace invasive physiological assessment.
Wow. Natalia, what do you think about that? That's a pretty big statement, especially for somebody who's using more imaging than physiology, I think.
So my point on physiology is that I think we move away from a single number like a long time ago. And I see physiology as an active procedure now. So we don't only get a number while we do pullbacks, we assess post-PCI. So I agree with Joost that probably angio-based or CT-based physiology are going to be important to select the population that will require a procedure. However, these techniques require a high resolution imaging for both CT and angio, and that will limit some cases depending on the quality you get. Once they are in the cath lab, I think the role of invasive physiology will always be there. Probably will decrease selecting the patients that will require a procedure. But still, we had studies ongoing of assessing post-PCI result, pullbacks showing you how extensive your PCI has to be. And I agree with just microvascular dysfunction scenario. So I think this invasive physiology is going to move forward an active procedure rather than just a number that could come from non-invasive techniques.
Yeah, so, you know, David, these guys are really excited about this. And I'm thinking, two orthogonal views, excellent, you know, splaying out and doing this angiography. I'm always worried about AKI, obviously, but also more importantly is the radiation exposure, especially if they've already come in with a pre-angio CTA that has brought them to the cath lab, which is happening more and more often. So are you worried about any of this?
I'm not worried too much for a couple of angio runs, but I take your point. Obviously, that is a bit of contrast. That is a bit of a stress on the kidneys. I think for me, the interesting thing is, and we participated in the FAST-3 trial, you can see angiographically that as the AI gets better and better, we will be able to get automated answers quite quickly about the coronary arteries. I suppose what I was thinking, though, was bearing in mind that we're largely talking about an analysis of stable patients, so patients who presumably have angina, what works better is to have a CT scan with excellent analysis of the vessels, the plaque within the vessels, the calcification within the vessels, so that then when you go to do the angiogram, when you go to the cath lab, you're forewarned and forearmed, as opposed to the technology where you're basically taking the patient without any information and then immediately assessing your angiogram and trying to get the sort of FFR out of the angiogram itself rather than doing more than that. Because basically once you're in the cath lab, you might as well use all the instruments you've got. So I kind of think the emphasis is more, from my point of view, sensibly on CT FFR rather than angio FFR.
No, it's great. Ajay, welcome. It's great to have you here. We're talking a lot about angio versus invasive FFR and physiology. What are your overall thoughts about this? Like, where do you see it in the future? I know you were very involved in some of the angio work.
Well, look, I mean, I think that it needs to be proven in a trial-based way and held to the same standard as a wire. And so that's one of the reasons why we're running a trial to look at that and to see if it's not inferior. I can tell you from a clinical workflow standpoint, it's certainly easier than putting up a guide and wires and doing all of that. Obviously, if you have it upstream with a CT, that's super useful, but there are still times in the lab where you want to make those decisions. But I think the biggest thing is that you have to be a good clinician and understand why you're doing the physiology in the first place. And so typically when I use physiology, I know why I'm doing it. And I want to answer a very specific question. And that question is, is a patient going to be fine typically if I leave this and defer this lesion alone? And so we can't think that if it's 0.79, we're going to save the patient's life. And it was 0.81 and we by stenting it. And if it was 0.81 and we left it alone, that's fine. The way we think about this is holistically in the patient perspective. So I think it's good to have multiple tools. I hope that this will improve the utilization of physiology, but it needs to be validated. And that's why one of the reasons why we're doing this study.
No, it's great. Well, thank you. And, Joost, that was such a fantastic talk. I'd love to talk more about the periadventitial fat and inflammation, because that's going to be a focus of a lot of biologics going forward. And I think that this is an amazing technology in terms of having the CTs beforehand. So thanks for that, Joost. But we're going to now move to Ajay. Ajay Kirtane, Columbia University. He's obviously well known to all of us, but he wants to tell us, and hopefully he'll help us to see how we could actually increase the implementation of imaging in practices. And Ajay, before I go to you, some of the questions here are, we in the third world nation can't afford all of this fancy stuff. So you're going to have to help answer that question as well. So take it away, Ajay. You have our attention.
Oh, thanks so much. And those are great questions. And, I'll make this a kind of a thought experiment type of talk, but we can hopefully get to some of those questions in the discussion. But, I think I just want to start off with just talking about, because we've been talking about a lot of different tests, and we should talk about what I think is the most overrated imaging test in the cath lab. And I think the truth of the matter is it's actually the coronary angiogram. And the reason I say that is because obviously coronary angiogram is super important, and it's what we use to base a lot of decision making. But there's so many people who are so wedded to the coronary angiogram that they don't actually open their eyes or put their glasses on to see that we should really be looking at things in a very different way, and whether that's physiology, imaging, or otherwise. So simple example of that I can show you, these are left main lesions. This is the slide I borrowed from Gary Mintz. The angiograms are on the top. Which of these left main lesions are significant? How should we treat them? If you don't do imaging or physiology, you're going to be wrong a lot of the time, because there are lesions that look real, but they actually by IVUS are not. There are other lesions that don't look like anything, but by IVUS, they're severe and beyond. So the left main, clearly prognostically important, and yet we use this to triage so many patients. And so the idea is not to image every single one, but to really have your guards up. And so to use imaging or physiology to adjudicate these cases, which have prognostic significance for patients. So the real question is, why is imaging underutilized? And I think there are a few reasons, three that I'll sort of talk about. And the first one is that I think many of us, know what we know. We're experienced, and we think we know everything, and we feel like we're experienced, and that my outcomes are great. So why should I do this? There's not an adequate data source for me to be able to change what I do. Well, that kind of falls apart, if you sort of pardon my pun with the slide, when you look at all of the data that's there. And by the way, I did this purposely. This is the slide from Gary Mintz before all the trials that came out last year, showing that there's abundant data showing that you can improve your clinical outcomes with the use of intravascular imaging. If you didn't fully believe it, all these trials that have come out recently, this is a meta-analysis just published in The Lancet, showing that, the most important outcomes such as repeat revascularization reduced, MI reduced, even thrombosis of the stent, even mortality reduced with intravascular imaging in randomized trials. Does that mean we need to do it for every single person? No, because most of these trials looked at complex lesions, but it certainly should, I think we start to refute those folks that feel that there's not adequate data to support it. The other issue, though, is that the one that was brought up in the chat. It's costly and adds time and effort. And my answer back to that is I was probably more sympathetic about this maybe 5 years ago, but I would also say that so are bad outcomes. Bad outcomes are costly, add time and effort, and are not good for patients either. And the existential question is that if you had a family member like your mom who was having a PCI, wouldn't you want the interventionalist doing it to use adjunctive imaging to be sure? Now, not every single patient is going to benefit from the use of imaging. The problem is we don't know who's going to benefit and who's not. And you find things when you image that you didn't know you did. So back to left main again, this is Akiko Mehran, a colleague of ours that everybody knows her around the world as the imaging expert, and just really, really enthusiastic. And it's great having her in our lab. But one of the things that she's shown from the Excel trial is that you pick up acute stent deformation of the left main, 7% of the time, and that's associated with an adverse event rate that's in the 15% range if you happen to pick it up. But you wouldn't have picked this up had you not done the imaging. So once again, prognostically important lesion subset, we really have to do a good job. And remember, in Excel, we didn't fully match surgery, despite the fact that imaging was used in 3/4 of patients. So if we're going to think that we're going to do a surgical-like result, we really have to do it in the right way. The last part, which is a real part, is it's hard for me to figure out what I'm looking at. And my staff complain. And so it's easiest for me to fall back on my experience with angiography. And I think this is based upon the fact that it's based on historical IVUS. Something we don't talk about enough is that when most people think of IVUS, they think of this fuzzy, grainy image that is very hard to interpret. They don't think about some of the newer modalities where you can really appreciate the structures better, you can appreciate stem stress better, and you can learn. And actually, it's literally like putting your glasses on when you couldn't see before. Now you can see a lot better. It's not to say that this old systems are not good enough. They're okay, but it certainly times have changed and we need to rely upon these newer systems. And you'll find if you do, it actually becomes a lot more intuitive. You don't even have to learn that much. In the ACC AHA Sky training statement, really they set a very low bar. They set a bar of just 25 imaging procedures during the course of a fellowship. I personally don't think that's enough to achieve competence, but once you start doing these, use the AI mechanisms, et cetera, like we've seen in the live cases, you can start getting pretty good at this faster than you used to when the images were really fuzzy and hard to look at. What do you need to know? You don't need to know a lot to size stents. You need to identify the distal reference. You don't size where the plaque is because the vessel's enlarged because of Glagov remodeling. You basically look at the distal, look at the proximal. That's your length in between the two of them with a automated pullback. You cannot do manual pullbacks. Everybody does manual pullbacks because it's easy. It's useless unless you have some co-registration to measure length. So you need the length. You measure the diameter based on the distal reference. That's how you size your stent, and you post-dilate it that way and keep it really simple. So that's one of the reasons why we feel, and we felt strongly as part of the ACC's Interventional Council, that we really needed to mandate imaging for complex lesion subsets. And we published this last year. This was not your typical imaging gurus. This was a bunch of clinicians who came together and recommended IVI, intravascular imaging, as an essential adjunct to angiography for complex lesion subset. It's not going to help every patient, but certainly in that complex group, you don't want to take the chance. So just to kind of illustrate this, I'll just show you a quick case. This is a patient that we treated at how imaging actually can change what you do in the case. You can see there's a nodule at the distal left main impinging the ostium of the circumflex, particularly in this view. It's kind of nasty, and ordinarily this would be a double limb rotoblader type of case. Here you can appreciate what it looks like here, and it's very retroflexed here. So the rotoblader is not without risk in this case. Well, beyond that, it was actually really difficult to wire the circ, and this is the microcatheter having difficulty going into the circ. So now you're thinking, okay, do we rotablate into the circ first? How do we do this case? Well, what I actually did is I did IVUS of the left main from the LAD, and what you can see is there's a nodule at 6 o'clock, and you'll see the circ wire come in right next to the nodule. There's the nodule, here's the circ wire. And actually, the rest of it's not that disease. And so my idea here was maybe instead of doing complex double bifurcation rota, I could double limb rota, I could somehow modify this plaque, and maybe I wouldn't have to do rota into the circumflex. And that's essentially what we did. Is I did an IVL, but you could use an NC balloon, cutting balloon, anything of the left main and the LAD, went back. And if you look at that, now you see the ostium of the circ has released because that nodule has moved away from the ostium of the circumflex. IVUSed again after doing it. And what you can appreciate is now this nodule, which was here, has moved to the right a little bit, making the ostium of the circ, here's the nodule coming in, and the ostium of the circ is now free and open. So maybe I don't have to roto-this. I'm not going to go through the whole case and show you that we dilated the circumflex, et cetera. But bottom line is that I was able to do single stent provisional left main into the LAD because I guided it by imaging. I looked at the imaging. I knew what I was interpreting. Stent to the LAD did pot, and the final IVUS basically showed a nice big luminary of 10. And this was the final angiogram showing that the circ was wide open. So imaging clearly affected the management of this case. It made it a lot more simple. It made it a lot more safe. And the patient's going to have a very good prognosis. And this was also important because the patient had a CKD as well. And we continued his standard dual antiplatelet therapy. So what's my summary? How do we improve imaging? I think we have to first start off by accepting that the angiogram is an important tool, but it has much broader limitations than most interventionalists admit. And that's why I think it's perhaps the most overrated imaging modality of all, and why we need to be open to opening our eyes and putting on our glasses further to see better. I also think that imaging and physiology have evolved. Not every patient's going to derive a benefit, but we don't know who's going to benefit and who's not. And unless we know how to use the therapies and know what we're looking at, how to interpret them, hard to affect outcomes. But know how to learn all the tools and be careful and sensible. Don't be dogmatic. Don't say I have to IVUS every single case or I have to OCT every case. Use your good clinical sense about you in their use. But I do think you're going to show improved outcomes, and that's borne out by the randomized data. Hopefully that was helpful. Thanks so much. I'll be open for discussion.
Excellent. Really great points, especially for clinicians. And similar questions coming up here. And first, let me ask you, Ajay, you kept saying, should we use this for select or should be for every single PCI, for every single lesion? We saw in Illumian 4, where probably it was less complex, and Natalia showed that the minimal stent area was no different, very different than complex lesions like Renovate PCI and bifurcation in October, et cetera. So does this mean that we really should be using this in the most complex, or whenever there's ambiguity, or how do you really decipher how to use this? Is it in everyone? It seems like that's what you're asking.
Yeah, so I think there's a practical answer and then there's a scientific answer. The scientific answer is that the data really is most supportive in complex lesion subsets because it's hard to prove in a simple lesion subset that you're going to affect outcome. And Roxana, you and I just wrote an editorial on a paper that just came out in JAMA Cardiology, not looking at IVUS, but looking at IVUS versus QCA and standardized QCA-based approaches. And although the trial was underpowered, there were pretty similar outcomes with really assiduous looking at the QCA and meticulous technique. So scientifically, it's going to be hard to prove. But the practical point that I think does drive up the use in general, and that's why we tend to use it in virtually all of our cases, is that you don't actually know what you're looking at in complex cases unless you have the requisite experience in a reasonable subset of patients to know how to interpret the imaging. So you can't just start using it in a complex bifurcation calcified left main like the one I showed you and be able to interpret that the nodule was away from the ostium of the circ and where the wire was. I don't think that's something that's easily translatable unless you have a fair amount of experience. But bottom line, I don't think you need to use it in everybody, but certainly if I'm a patient, I would hope that my doc used it.
David, what are you doing in your practice? Is it in everyone or is it just certain patients?
But it probably should be. So, it is clear, and the evidence shows that if you're going to put a stent, which is fundamentally a permanent scaffold implant inside the coronary artery, you should put in the right length and the right size. And that really warrants using IVUS or OCT. And I thought Ajay's talk was absolutely great because what he did was he came to the real world and said, well, hang on, we know that we should be using all the time, so why aren't we? And I think sometimes we're not quite honest about this. Yes, people say it's money, and that's true. Yes, people say it's time, and that's true. But it's also really the familiarity that Ajay talked about and the confidence. So a lot of people have spent many years looking at the most imperfect test, as Ajay said, the coronary angiogram, and saying, okay, I really understand that now, and haven't spent the same amount of time putting the hours in to learn that about IVUS and OCT. Of course, the next generation coming will increasingly do that. But for people who've been doing this for many years, yes, their familiarity and their confidence in front of their lab staff, they don't want to look foolish in front of their lab staff. So their confidence in using these modalities is less good. And we have to be humble and say, okay, fine, there's new technology. I really need to learn it well, just like I learned coronary angiography well. And that's one of the reasons, one of the key reasons, I think, why the uptake of intracoronary imaging is lower than it should be.
Yeah, any comments from Natalia and Joost before I ask you the other question that just came forward?
Yeah, Roxana, I just wanted to say that I totally agree with Ajay. Like, I think in the learning curve for all of us, we need to do actually easy cases. And that's what we recommend when we are doing training. Don't do a bifurcation. Don't try a LMA. Just you do an easy focal LAD that makes you feel comfortable with the system, with the measurements, with the planning. And don't jump into doing a calcific RCA for the first time. And that learning curve is the one that makes you confident to use it in complex cases. And in my own experience, what happens with imaging is you start seeing how you will change your strategy, even in focal easy lesions. So if I'm looking at an angiogram and I'm thinking, oh, I'm going to do a 312 millimeters stent, I end up doing a 4x23. So I think the change in your strategy is even in simple focal disease. So the more you use it, the more you want it to use it. And I agree with Ajay. If I were the patient or if that was my family member, I think I want imaging in all cases.
Yeah, for me, it's amazing what I think by angiography and then what I see by intravascular imaging. And when it's really different, it's like, oh my, what was I thinking? And then you really are turned on. Well, one question that's come up is when you use imaging, should it be before or after stenting? Should it be just after stenting if we're just worried about the final outcome? And I mean, I have my answer, but let me go to you, Joost. What do you think?
Yeah, to me, Roxana, this is a no-brainer. I mean, we've seen so many of these amazing case examples. Ajay just presented a couple. Imaging lets you identify calcium. Angiography underestimates calcium. If you just do your post-PCI assessment, you miss all of that crucial information that will help you to tailor down whether you will get away with just a simple non-compliant balloon or whether you have to upgrade to more expensive atherectomy technology, shockwave, or whatsoever. So to me, the pre-PCI assessment is critical in order to get the best appreciation of the lesion type, to pick the right lesion modification strategy. Then repeat the imaging, because if you spend $5,000 on a shockwave balloon, you want to see if that balloon did the trick. I mean, there's no point in just using the balloon, put in the stent and look for the post-PCI assessment. In my perspective, you really need to do at least 2 to 3 assessments in order to get the best out of the image.
I mean, I couldn't say it any better. I mean, you have the IVUS catheter there. Use it to the best for every single thing, and it just takes a couple of minutes. And, well, this has been a fantastic session. And now we're going to transition to live cases. I need you guys here, and we're going to go, and I'm really confident it's going to be great fun. And in this particular session for the live cases, we're going to connect with 2 U.S. centers. And I'm really excited because the first center is my center, my colleagues at Mount Sinai Hospital. And Dr. Kinney, Anu Kinney, one of the highest volume operators in the world, and Dr. Dangus are waiting for us. So let's go to Mount Sinai in New York City.